Thank you, Robin. Next up, we have Stacie Pallotta, who has more than 10 years of healthcare experience in clinical and translational research, project management, and healthcare administration at research and academic medical centers. She joined the Cleveland Clinic in 2005 and is currently Senior Director of the Office of Patient Experience. Pallotta's areas of focus include culture and service, best practices, external partnerships, and volunteer services. She also oversees the Association for Patient Experience. Her role in the Office of Patient Experience has allowed her to partner with key members of human resources to drive organizational culture development, employee engagement initiatives, and service training and sustainability. She's also worked a lot with Cleveland Clinic's international partners in developing patient experience strategy, including customizing it for local environments and implementing best practices. Welcome.
Thank you. Good morning. See, it's great to come from Cleveland, Ohio to Denver to Keystone because I'm actually feeling like I'm ahead, being in mountain time. So right off the bat, I'm very excited to be here, and I'm actually feeling even a little bit ahead today. So it's a pleasure to be here, and I hope in the next half hour I can share with you a bit of a story. And this is really the story of the Cleveland Clinic that I've had the privilege to be a part of. And whereas my co-panelists have talked to you a lot so far today about technology and some very cool global initiatives that are helping drive healthy living forward, I'm going to talk to you quite a bit about engagement of people. And so how people shifting that environment, at least for us, has just been key in the success that we've seen over these last couple of years around patient experience. So first, just a little bit about us. We are an integrated healthcare system, so we have over 1,200 beds at our main campus. In the grand scheme of national healthcare, we're considered a large facility. So there are 15 hospitals that have over 1,200 beds. We're number 14 on that list. We have 11 regional hospitals, 18 family health centers, and then we have a bit of a national and an international presence. And I'll tell you, I swear Las Vegas is the most exotic thing up there. It's just my opinion. Our revenue is about $6 billion. We have 43,000 employees, and for better or for worse, we found ourselves being identified as a patient experience leader. And I say for better or for worse because when you're leading a pack, that's a great feeling until you realize you're leading a pack, and then it becomes a matter of how do we keep this bar high? How do we help people along the journey? How do we become transparent about what's worked and what hasn't worked for us? And how do we recognize that this is an international phenomenon, this idea of patient experience? It's a lot of responsibility to be a driver of it. So that's all the great stuff about us. I'm going to let you read these next 3 points. So if you're familiar with the Cleveland Clinic, the clinic has historically been known for outstanding clinical care. If your heart is broken, we literally probably can fix it. Great, but it's a bit like the 800-pound gorilla. So people were coming to us because they had to, because they felt like they had no other clinical options. U.S. News and World's Report, right? Top number one hospital, or Heart and Vascular Institute, again. That's a great thing, we're proud of it. But it wasn't enough for us anymore to just say we perform outstanding clinical care. It just wasn't enough. And it wasn't enough for a couple of reasons, which I'll dive into. But not only did we have this bit of an ego around us of this great clinical care, we had patients that were starting to articulate, we don't want to be here. We had employees who were telling us they didn't want to be there. We're one of 3 major medical systems within probably a 20-mile radius. So whether you care about that on a personal level or you care about that on a business-minded level, that's a huge issue. Bottom line, people were coming to us, but they didn't like it. So I'm just going to show you 2 quick slides of data, and this is just to show you a little bit around how we have been successful. Our work around culture transformation began back in 2009. That's when we really started acknowledging those first 3 points on the slide previously. Would recommend, this is an HCAHPS would recommend question. I'm guessing most of you are in the room are familiar with HCAHPS and are familiar with this question. So we ranked last of the hospitals that were like us. Of those 15 large hospitals, we ranked last in the would recommend category when we started this adventure. We also ranked last in the overall rating. Probably not shocking to tell you, we also ranked last in every single domain. But you can see from the 2013 data, we're doing a lot better now. And it's a privilege for us because whereas we were calling places like the Mayo Clinic back in 2009 and begging them to help us, they're knocking on our door right now going, hey, not only have you guys done it, but you're sustaining it. Can you help us? Much better side of the coin to be on. Feels much better. So let's talk a little bit about why does this matter? And I suspect many of you in the room understand and appreciate these points, but I think they're very valid to take a moment and to reflect on before we move into the what we did. So this slide, the healthcare consumer has changed on us. And whenever I show this slide, I think of an experience that I had back a number of years ago now. I took my grandmother to a doctor's appointment. And so I was 20-something, she was in her 80s, and Grandma dressed up for the appointment. Like, not kidding, went and dressed up for the appointment. And we walk in, and the doctor comes into the room, and she sits up straighter. It's my little 80-year-old grandmother trying to sit up straighter. And she wasn't riding horses, so it wasn't like we had that precedence for her. She sat up straighter, and it was yes, sir, no, sir, thank you, sir. She was a polite woman, but I'd never seen her behave to that extent of politeness. And there I am, in all my Generation X angst, in the corner on whatever early version of the iPhone was out, looking up information as he was saying it. Well, is this medication going to interact with her other medication? And should we get another opinion? And I think of that because while I was in it, I still think it was a great reflection of what this slide represents. It's not enough anymore for physicians to say, I want you to go see this doctor, and people go do it. That's not what healthcare consumers are telling us. They're telling us the overall experience matters to me. My expectation of clinical care, particularly in the US, is at a certain level, period. I want to feel like I'm in an environment that promotes healing. It's not just enough to have the clinical element. I want to be overall cared for. Huge shift in patient consumerism. Second slide. Bottom line for the Cleveland Clinic, this amounted to $12 million. So, talk about a great reason to get your finance people and your administrators on board. Patient experience is the right thing to do anyway. Most of us would agree with that. We chose this field. But for some people, another reason or an added element is really important. 12 million sings pretty loudly to an organization. The last point then was that we had an incredible aha moment. And this is a story that I'm very proud of our organization for telling and retelling, and I'm going to share it with you. So Toby Cosgrove is our CEO and president, and he led this shift, this cultural transformation for us. And his big pivotal moment was that he was at Harvard, and he was speaking to a group of MBA students. He was going over the operating model of the Cleveland Clinic. Our history, 1921, physician established, physician led, we'll get to that later, but physician led model, institute based, walking through the entire operational model, and at the very end, he opens the floor to questions. And so up goes, 20-some-year-old MBA student's hand, and she says, Dr. Cosgrove, I have a story for you, and then I have a question. And so this is what she shared. Her father is a gastroenterologist who lives in North Carolina. And he had to have mitral valve surgery. So right there, she already had Toby hooked, because granted, he's the CEO and president of a very large healthcare system, but at the end of the day, he's a mitral valve surgeon. That's how he started, and that's what he does. So she had him hooked. And she said, we did an evaluation and compared data of where he would receive the best care. And so what we found was that both you at the Cleveland Clinic and Mayo would likely provide great clinical care. Your core measures are good, your outcomes are good. We found them to be comparable. So that's where the fish is out of the water, because we view Mayo as a friendly but still competitor, and always there's somebody from Mayo in the room. So trust me, I say that with incredible respect. So the fish is now out of the water. And she says, we chose Mayo. So that meant that this family, who could have chosen healthcare anywhere, flew over Cleveland, Ohio, to get care, mitral valve surgery, at the Mayo Clinic. And she said the reason we chose Mayo was because we had heard that the Cleveland Clinic isn't very nice to people. So she said, my question to you, Dr. Cosgrove, is do you teach empathy? And the way the story goes, you could hear the pin drop. The campfire had been built, right? Patient experience was being linked to CMS, was being linked to payment. People were in this field because they felt it was the right thing to do anyway. The healthcare consumer had changed on us, and that's where that match got thrown. And Toby came back, and he told that story and retold that story and retold that story and said, we need to do something. So what to do? He started by taking a look at what exactly defines experience and what does patient experience mean, not just to us from an organizational perspective, but to the healthcare consumer, to the patient, to the family member of the patient, and then bigger than that, to communities at large. In order to do that effectively, we had to take a critical look at our current culture. And so we were rampant with this. Remember I mentioned we were physician-run? Oh, we were physician-run. And so as much as this is tongue-in-cheek, it was very much how we typically would approach patient care. We also had a bit of this happening. So it's one thing to start defining an experience, but what happens when a patient is touched by so many people over the course of a stay with us that they're not differentiating anymore who was the nurse and who was the MA and who was environmental services, but rather they're seeing a Cleveland Clinic badge and they're equating you as one giant organization. A little story here. My boss is the chief experience officer at our facility. His name is Jim Merlino. And he actually is a colorectal surgeon. And I'll give you a minute to make your own joke in your head about that. And so Jim asked one of his patients who had come in for a rectal cancer surgery to keep a journal. And what he asked her to do was have everybody who came into her room sign the journal, just sign their name. That was it. Okay? And so background, completely by the book surgery, no complications. Any guesses on how many names she had? 20? 50? 78 names. 5-day stay. And what she said was, Dr. Merlino, actually she probably called him Jim, everybody calls him Jim, I think except me. Jim, I'm so sorry, a couple people, I didn't get their signatures. So we needed to acknowledge where we were, and we needed to acknowledge how that was going to fold into where we wanted to go, and most importantly, how we were going to get there. So any good culture change starts with not only acknowledging what's maybe you want to shift about your environment, but also what's really good about your environment. And we had this that was really good. We had a patient's first mantra. People knew it. They said it. Clinical care providers could tell you what this meant. They understood how to demonstrate, how to behaviorally represent patients first. So we wanted to amplify on that. We also wanted to extend it, because while clinical care people could tell you what this meant, non-clinical care people had a heck of a time trying to connect the dots and articulate what patients first meant to them. But it was a strong enough message, and it was embedded enough in our organization that it was something we wanted to expand upon. So in order to get there, we linked the idea of patients first with patient experience. And we had to set some definitions. So not only telling people what it meant, asking people what they thought it meant, we also needed to ask people and then ultimately tell people what it didn't mean. And this is what it doesn't mean to us at the clinic. And it's very interesting because I've heard healthcare organizations talk about the role of satisfaction and equate it with patient experience. And I've heard other healthcare organizations like us say, oh, no, they're not the same. And I'll tell you why we do not define satisfaction as the same as experience. You have a patient who's a drug seeker. Patient comes in, wants scripts. Do I not give them scripts? Because guess what? If I do that, they're going to leave, and they're not going to be very satisfied. Another example, diabetic patient. I don't want a restricted diet. It's appropriate, in fact, it's imperative that we provide good clinical care to that diabetic patient, which includes a restricted diet, but how we communicate that is the crux of the issue. So satisfaction is not the same as experience for us at the clinic. In fact, this is how we define patient experience. This is how we define patients first now. And these 4 bullet points are easy to remember, and they're in priority order. So safety, first and foremost, followed by high quality, Satisfaction is a component. And then the last point is high-value care. So to compare this to the airline industry, did you take off and land? Did you do it on time? Satisfaction, I think I had a choice of peanuts or pretzels on United on my way here, so there's satisfaction for you. And then high value would be, what did you pay for the ticket? This sets a roadmap for people. So when that clinician is saying, oh, you want me to give the diabetic patient a cookie? No, of course not, because that violates safety. We don't want you to do that. We don't want satisfaction to trump safety. Rather, we want you to think of these in priority order. The other thing that this did for us is that it helped people start to think about these elements not in silos any longer. If you improve satisfaction, odds are good your quality is improving too. Very, very rarely have we ever seen one go in a positive direction and one go in a negative direction. They hang together. They naturally hang together. Another thing we thought about or started thinking about, and this is a bit in line with the idea of siloing, was this continuum of care. In our organization, we had some great people who were really excited about patient experience and providing a patient's first environment, but they were doing it on a very microscopic level. So it's my interaction with you, and as far as I'm concerned, that's your patient experience. Well, guess what? That's not your patient experience. Your patient experience looks like this. From the minute you pick up that phone and you call the Cleveland Clinic to inquire about an appointment all the way through to your discharge, acknowledging that sometimes you're not discharged home. Sometimes you're discharged to hospice, to a long-term care facility. Patients don't care about those touch points other than they are part of the scope of their overall experience. Something very difficult for us to get our heads around. But to this idea of really how do you instill change? How do you encourage engagement? You know, it's not just about empowering the individuals, it's about empowering the individuals to make an environmental or a system difference. And that's really what this came down to for us. So this slide then is what we adopted to help explain our execution plan. And we used this over and over and over again across our organization. I'm just gonna walk through it quickly here. So across the top, those 4 blocks represent the slide I just showed you, that idea of a continuum of care, looking at it from the patient's perspective, not just from our perspective as an employee or a care provider. The culture of service, critical, absolutely critical. We had lost ourselves in our own journey of clinical excellence. We forgot how powerful a smile is to someone who's confused and who's lost. We lost the idea of empathy and how to connect with people on a very, very basic fundamental level. And we stopped acknowledging that while sometimes we can cure, sometimes we can't. Sometimes all we can do is create an environment to promote healing. A service of culture will help encourage that in your organization and it'll help instill it. People, process, and patience then, we heard about the 3 A's earlier. Here's the 3 P's for you. So process, are your processes seamless? Can a patient come and have an appointment in our Digestive Disease Institute and have an appointment later that day in our Heart and Vascular Institute and not feel like they're going to a fundamentally different place? It's like Cleveland to Colorado. They're both great. Colorado's better, but Cleveland to Denver maybe. They're both great, but boy, are they different. And so again, under that emblem of Patients First, under that blue and green logo that is Cleveland Clinic, how do we make sure those processes feel good? One of the ways we do this, and we heard about it a little bit earlier, is the power of the electronic medical record. Because let me tell you, a patient that goes to Cleveland Clinic Abu Dhabi and a patient that goes to Cleveland Clinic Cleveland, Ohio, the fact that we can pull up medical information automatically creates a sense of security for them. Really, really important. People, right boss, and right seat. 90-year history, we're facing a culture change where we want to instill this culture of service. We want to make that our foundation. We knew we had a lot of people in the organization who maybe weren't exactly in the right seat. Maybe they weren't even on the right bus. Maybe they had been sitting there for 30 years. Who's going to go tell them they have to move? So the idea of how do you hire and attract and then retain the right people? And for us, because this was a shift, how do you escort the people who aren't a good cultural fit for this new beginning out of your organization? And how do you do it with empathy and with caring and with concern? And then the last part is patience. And this is the part that we've really been lagging on. We've just started tackling this the last couple of years. How do you effectively engage patients? How do you communicate to them consistently? How do you communicate things they don't want to hear? I'm sorry, you're diabetic. You can't have a cookie. Probably not the right way to communicate that message, but that point needs to be made. How do you do it in a way that then helps that patient become part of that process? What else can you have? What else do you like to eat? Things like that. Also, I'll make a note here just around the idea of VPACs, which are Voice of the Patient Advisory Councils. I get a lot of questions around how are you engaging patients carefully, but absolutely we're doing it, and we're finding all kinds of ways to do it. Everything from these committees or these councils to we have an online panel of over 10,000 people where we can reach out and ask questions, get opinions, get ideas. So really engaging patients around how do we want to deliver healthcare moving forward. So that was Dr. Cosgrove's kind of let's come back and take a look at current state and figure out what we're going to do. And these next couple of slides now are going to walk you through what we did. We decided that we needed to leverage culture development. Notice we don't say change much anymore. Changing suggests that you were bad and we're going to make you good. Rather, this was an evolution for us. So cultural development to improve the patient experience. Right off the bat, we built a process, we built an initiative that acknowledged this. Patients first, up at the top, but our challenge was that doctors were a close second. Arguably sometimes more important than the patients, and everybody else fell to the sides. So we did this. Every person who works at the Cleveland Clinic now is a caregiver. Our badges say it. We have a badge backer that has the word caregiver underneath. The initiative that we instituted and that everybody participated in focused on this idea. How does every person in the Cleveland Clinic health system contribute to the patient experience? There's an accountability piece, there's an expectation piece, but there's also a privilege piece. How do I, as an administrator, get to impact patient experience? It doesn't have to be complicated. For me, it was as simple as I need to put down the iPhone when I'm walking through our cavernous hallways, because you know what? People are lost. And there is no way that I am that busy or that important that I can't be looking up, so that if people need help, they feel that I am more readily approachable. The initiative we adopted was a learning map session. And again, this is a very high-level overview, so bear with me here. But basically, we had one consultant come in. We didn't want a lot of consultants around this idea. We're very culture-centric. If it wasn't done at the Cleveland Clinic historically, we didn't think it was very good. But we're getting there. We're better now. We're recovering. But because of that, we didn't want a lot of consultants coming in. We wanted to do this ourselves. The one consultant we did have come in created this for us. They listened to our executive leaders talk about what is the vision of Cleveland Clinic. What should it look like? What should the Cleveland Clinic experience feel like? We tested this then. Groups of caregivers, patients. We revised it as we went, and ultimately what you see here is the map that we ended up with. What this did was create a dialogue platform. We had groups of people come together, randomly assigned, tables of 8 to 10, around a table. Set of questions, conversation, dialogue topics. We talked about mission, vision, and values. We talked about how we hold each other to our values. We talked about the desired service behaviors. We had a great service model in place. We had the Communicate with Heart program in place. Not everybody knew about it, and certainly not everybody was very good at it. So we revisited the service model in our organization. We focused on service recovery. And I'll tell you one of the coolest things about this focus on service recovery was that by the end of this journey for us, by the end of Cleveland Clinic Experience Map sessions, our number of complaints bottomed out that were as recorded by our ombudsman office. And it bottomed out so much that we actually checked the software platforms. We were sure there was like a pile of them sitting somewhere. We were checking our IT connections. And actually what it came back to was the fact that we now had 43,000 people who were equipped to do on-the-spot recovery, as opposed to the line of, here's the ombudsman's card, take it to our 12 experts. So just a little side note there. That was the mapping session itself. We did the map in about 2009. We did a lot more around the map than just what you've seen there in terms of leadership readiness. And we started talking about sustainability at that point, but quite frankly, we didn't get on top of it like we should have. We think we were very nervous as to whether or not the map would even work. We were a very productivity-driven organization. So this idea of getting groups of people around a table to talk about how they feel and how they can contribute and how they can work with each other. Remember, around this table too, I said was random assignment. This was everybody. Neurosurgeon sitting next to environmental services person, sitting next to an administrator, sitting next to a nurse, all talking about how they contribute to this overall Cleveland Clinic experience. Very, very different than anything we had done before. So we were a little slow on the sustainability piece, but we've caught up. And what I've got here is just a slide that shows you some of the different sustainability elements or the ways we've approached it since the Cleveland Clinic experience in 2009. System leadership rounding. So now in our organization, we have regularly scheduled rounding that occurs. We have leadership rounding, which is executive leadership. It's about 100 people on our main campus. It's done at the same day, on the same day and the same time zones permitting, across our healthcare system. The groups are 3 people. They're randomly assigned to an area, both clinical and non-clinical, and they simply walk around and ask, how's it going? What could we at the Cleveland Clinic be doing better for you as a patient? We talk to family members, what's your experience been like? And we talk to caregivers. What do you like about working here? What do you need to make your job easier? How could you improve the patient experience? What's a barrier for you? This has been in place for about 3 years now. All the data is centralized, and then it's sorted by our Office of Patient Experience with action items. So there's a feedback loop for it. It's been very successful. It's actually an idea that we took from UCLA, and I'm very pleased to share they came out and visited us about 6 months ago because we had taken it and we're doing it better. So they were very excited to learn how we had improved upon it, which is when it really gets fun, when you get into this community of sharing around some of these tools. The second one is physician training. So we created a communication training program specifically for our physicians. It's taught by our physicians. It's matched. So an internist teaches to internists. Again, being very respectful of the culture of where you are versus the culture of where you want to go. We would never send an internist or a pediatrician in to talk to our seasoned heart and vascular surgeons. Just wouldn't work. But so it's very matched based on peer level and experience. The training is all about empathetic communication, and we've got data around it. 2 things we've learned with physician engagement. 1, make the data transparent. The second thing then is to really show the data as to why this is helpful or useful to them. Completion of this training program shows 3 big things. 1, physician communication scores go up. It's the HCAHPS scores. 2, your malpractice rates go down. And 3, your quality of life goes up. So that's data that's pending publication now, but it speaks very loudly. Who wouldn't want those 3 things? It's throwing a great party. It's not forcing anybody to come to it, but it's throwing a great party and inviting people to be part of it. Leadership forums. 2 to 3 times a year, we have sessions just for the 2,500 leaders in our organization to get together and to deep dive into concepts around our values or around our mission or vision. They're very connected to Cleveland Clinic experience. We always did these, but quite frankly, they were always very fragmented. So now anything in a leadership forum that doesn't connect to Cleveland Clinic experience doesn't come as a topic for us. Everything's connected. Communicate with Heart, I mentioned before, that's our service platform. So we revisited the training both for upfront service behaviors as well as service recovery. Succession planning, we're just really getting into this now. The idea of how do we identify up and coming leaders, not just based on productivity measures. Remember I mentioned right people, right bus, right seat? We had people in the wrong seat sometimes because although clinically, for example, they may have been very skilled, we hadn't provided appropriate soft skill development or leadership training. And then this last point is really around caregiver engagement, and I'm going to end by showing you a video here. Back to that whole, Dr. Cosgrove, do you teach empathy? Empathy and emotion has been the underlying theme of our change. We wanted to bring this more to the forefront of our organization. And so some of you may have seen, we created an original empathy video. You can find it on YouTube. That's not the one I'm going to show you today because quite frankly it's overplayed. But we created an original empathy video that rallied people around the idea of everybody brings a set of emotions to an experience. This video that I'm going to show you is the sequel. And this just shows that we are a brave organization because typically nobody likes a sequel. So we'll see how you do with it. But this is a sequel. And so we wanted to build upon that idea of empathy, but we wanted to take it in a slightly different direction. And this direction that we wanted to take it into has a little bit more to do with that level playing field and helping connect individual caregivers then with that idea of patient and being a patient. So at that, I'm going to go ahead and ask that we show the video.
I had heard what no woman ever wants to hear: you have breast cancer. And I remember sitting up and go, what did you just say? And she said, yeah, you have breast cancer, it's confirmed. I walked out of the breast center and I stood in the lobby going, oh my God, what the hell just happened?
I had a very uncommon occurrence. When your pancreas explodes, as mine did, it felt like somebody cut me wide open and put a red hot frying pan in my abdomen. And that happened over minutes. I went from living my life to as about sick as a human being can be. Over the 4 months of hospitalization, I had 20 operations or major procedures. My wife literally camped out at my bedside every day because we didn't know if that was going to be the last day.
I had to have a CT of the abdomen. That's where they found out I had a mass on my kidney. I'm like, oh my God. Just to hear the word cancer can blow anyone away.
I was driving home. I didn't feel right. My car drove off the median, dropped about 30, 35 feet. I had a seizure, broke my back, sternum, ankle, a lot of things were broken.
I spent about 3.5 weeks unconscious and really had almost none of my major organs working. And yet I was hearing many conversations quite sharply. My family had 2 discussions about end-of-life care. I had the thought how interesting it was that I was watching myself die.
When I initially was diagnosed, how it was presented to me could have been maybe a softer touch. I mean, she scared me. I mean, it's scary stuff to begin with, but she knew I was alone. All I was worried about was living. I wanted to dance at my daughter's wedding. I wanted to hold my grandchildren.
Having that fear, not knowing what the outcome was going to be.
I was being sustained only by tube feeds. I was unable to eat. It was very difficult to do almost anything. So to be reduced to somebody who's essentially dependent on others for almost every facet of your activities of daily living is really difficult.
It's sort of a helpless feeling, especially when you're immobile. That's even more helpless because you really rely on them for everything. So having that one-on-one communication, because really you're waiting there and you're laying in that bed all day and all you want is 5 or 10 minutes. That's it.
So during my ICU stay, I lost 50 pounds. Every time that the nurses and others came to turn me, to change the sheets, clean me up, it felt as if my hips and my shoulders were coming out of joint. When you have completely lost your ability to care for yourself, you find yourself vulnerable and with limited dignity left.
Be kind to the person in passing, walking a little slower than you. You don't really know what they're going through.
A lot of people tell me, oh, I know how it feels. You know what? Until you become a patient, no, you do not. Those feelings are entirely different. Yes, they are.
I could tell within seconds of a caregiver entering my room of whether they were in the moment and actually caring about me. It's a sense that you know if they're there to help.
Whether it's from holding their hand or patting them on the back. All those things end up being very important. Sicker you are, probably the more important they are.
When I feel like I'm at the end of my rope sometimes during a busy day, then I try to put myself back in that bed. And then when I see somebody who might be angry or who might be frustrated, I remind myself what that feels like to be there, and then it makes sense.
Thank you. Thank you. So just one parting thought on that video. How are we engaging people in our organization to rally around the idea of patients first? I think you just saw it in that example. It's really helping people focus on the idea of creating an environment that's empathetic. So thank you so much again for the opportunity, and thank you for your attention today.
Thank you so much, Stacie, even though I saw a few other people wiping their eyes. That was lovely.
You know, if you don't have engagement, you don't have anything. One of the things that I've done, and I think the Colorado Health Foundation actually does, is focus on helping people figure out how to be successful in collaborative conversations. And I learned early on that if you want to have a problem genuinely be solved and solved for the long term, everybody around the table needs to see a win in it for them. And that's engagement. If they don't see a win, they're gone. So the Colorado Health Foundation has not just thrown pockets of money out of car windows. They've been invested in making sure that the problem is one, in fact, that needs to be solved, that the people who are trying to do it get good support, technical assistance, and then they stay with you to celebrate when you get it right. What was reaffirmed for me this morning is you have to be working in a culture that where people feel valued and they all get it, that they're doing something important, or they don't do a good job. And if you don't do a good job, you don't have a good program, and good services aren't delivered. So this was a reaffirmation for me that how you're being in relationship with the job that you're trying to do is critical.
At the Colorado Health Foundation, we really think that we all need to be engaged in our health. That seems pretty obvious when I say it like that we are responsible for our own health. We need to make sure that we have access to all the things that make us healthy, but we shouldn't go to the doctor and say, tell me what to do. We should be knowledgeable. We should learn. We should have the resources with which to learn and take charge of ourselves. And that's how I think of being engaged. Even though we may think we're saying things in a way that resonates with people, you know, it may not, because they may be looking at things through a different frame. So before we try to get somebody engaged in their health, we find out what their needs are. And then we try to figure out, where does health enter in? The symposium, I think, is a real reflection of the energy in Colorado for making this the healthiest state. We at the Colorado Health Foundation could never do this or even aspire to doing it alone. We need the energy that you see in this room, that you see here at the symposium to make this happen. And I feel like there's so much momentum. I always come away saying it's the participants, it's the audience members that really make this the special thing that it is. And why people come back over and over again is because they want to participate with people who share that value of we all deserve to lead healthy lives.
We are local, we are Colorado, and we are looking to increase engagement and to encourage it. We want to hear from our members and hear from all of Colorado about how we can do this better. I am really working to try and figure out how to create clear messaging that will reach the people of Colorado to help them understand how to take ownership and control over their own healthcare choices. It's such a confusing industry. People care so much less about the high-level theoretical approaches and so much more about how does this affect me? And that's what my job is to try and figure out how I can tell them how this affects them and how they can take action to make the best choice for them. I think that engagement is so difficult. People get overwhelmed or sort of backed into a political corner when you just mention healthcare. It's, are you for or against Obamacare? Do you call it Obamacare or the ACA? That there's so many tensions going on that I really appreciate a place where we can have a conversation and say, what are the policies? What can we do to come together to the table to understand that we're just trying to keep people healthy and that the focus is not just on treating people when they're sick, but as a community supporting the health of that community.